Good morning, everybody. My name is Shauna Duncan. I'm Korean English ancestry. I want to welcome you to the UBC's Learning Circle today. We want to acknowledge first that we're honored to be able to be working together on the unceded occupied traditional territories of the Musqueam Nation. Today's session is going to be on baby friendly, and we've got Gerry Kasten and Marianne Brophy with us. And very excited to have them and hear what they have to say. Before we get started, we always need to remind our viewers for all sessions that if you become upset or triggered, please ensure that you have a support system set up in advance for yourself. This can mean an elder, a trusted mentor, friend, family counselor, or a crisis contact number. So that's something that we mention every time with every session, just to be aware of that so that you have a support system in place for yourself, just in case. So very excited to get started on this, and I would love to hear Gerry and Marianne actually introduce themselves in their own words for you. And thank you for joining us, everybody in video conference and everybody on webinar today. Yes, Marianne, would you like to start?
Thank you, Shauna, for inviting us. It's very exciting to be here with you. I have a long history with the Baby Friendly Initiative. Was originally trained by UNICEF in Africa and have worked with Baby Friendly in Canada since 1997. So I have a lot of stories that I'm looking forward to sharing with you, and I'm very honoured to join you here today. Turn to Gerry.
As many people may know, I'm one of the dietitians working with the First Nations Health Authority. I also work with Vancouver Coastal Health and with UBC. And my involvement with Baby Friendly is a little more recent than Marianne's, but still probably goes back well over a decade. So,
long time.
Long time is.
Yeah. Exciting. And you've got some important information you're going to share with our viewers today.
Yes.
Yeah.
Shall we begin?
Yes. Go
Okay,
ahead.
let's advance.
So
There.
the webinar, we're a little bit delayed on your PowerPoint, but it's going to be up any second. Our techie person is working on it. And so just be patient with us. And first of all, is the PowerPoint going to be available to our viewers later?
Yes.
If we turn it into a PDF. Okay, so
Yeah.
you will have access to the PowerPoint after. We'll put it on our page after we're also finished with the video, and that'll be polished up and put on our webpage also. So we're going to get started now with the PowerPoint. So maybe you could use some more description for those
Absolutely.
people that aren't viewing it at this very moment.
So the Baby Friendly Initiative, a lot of people use the term baby friendly to mean all kinds of things. They might mean, oh, we promote breastfeeding in our facility, or they might mean, oh, we don't sell formula, or they might mean, we're just sort of generally all round behind breastfeeding, right? People use the term baby friendly in many, many ways, and so what I wanted to point out is that the Baby Friendly Initiative is actually a certification program. It's actually a thing that people use the term a lot. They use it, I was thinking, it's not an adjective, it's a proper noun.
Okay.
And so what it is the Baby Friendly Initiative is this certification program that reflects the care that women and infants receive from the time they go into the hospital as they return to the community, and their care throughout a child's early life in the community.
Okay.
So it's that whole continuum. In some countries they call it the Baby Friendly Hospital Initiative. Here in Canada we've recognized that it's not just hospitals that provide care, but communities as well. And so we just call it the Baby Friendly Initiative. Right? It was established to protect and support and promote both initiation of breastfeeding and duration of breastfeeding. In First Nations in BC, we have great initiation rates, and we have some of the longest duration rates for breastfeeding. Most people are initiating, but by the time we get to 6 months, the continued breastfeeding, particularly exclusive breastfeeding, has fallen off quite dramatically. And so a lot of times when I'm talking today, I'll be talking about extending duration, because we're doing quite well on initiation. And so really looking to extend duration. Did you have a question, Davina?
No.
No? Davina's sitting where no one can see her. So occasionally if we talk to someone off screen, it's Davina that we're talking to. Looks like we have some minor technical difficulties. But what we know about the Baby Friendly Initiative is that when it's implemented, breastfeeding initiation rates go up and breastfeeding duration rates are extended. So it's an exciting program, and it's been around, Marianne can probably say, it's been around for a long while. It's like
1991.
1991. And we're just getting to it here. Okay, let's advance. And so the question arises, why do we want to be baby friendly? Why would we want to undergo certification under a program? Just get a picture on the wall that says, we're certified. Right? What we know is that when people certify, a number of things come into place that support people in the community and in healthcare settings. So it supports women and children, right? Women and their infants, and it ensures that no matter which hospital you go to, you get the same kind of care, and as birth progresses, you get the same things happen all the time. Once babies are born, they're placed on mom's belly, right? That they're roomed in with. Marianne's going to discuss all of the criteria that are involved. I'm just going to scroll this part. Oh, there we go. It also ensures that breastfeeding is valued, right? That what we see is an emerging trend where people are really interested in supporting breastfeeding. But there are still pockets where people are somewhat resistant to breastfeeding because of the sexualization of breasts, right? It's really interesting in Brazil, where bottoms are more sexualized than breasts. Breastfeeding rates are doing somewhat better.
Yeah.
It also means that women have control over their own bodies when they're in healthcare. And we also know that there's lots of skills, that we see more and more skilled facilitators working in healthcare settings and in the community when the Baby Friendly Initiative has been implemented. So it's not just the women, but it's the people who are offering care for the women and their children that are benefiting. So they're benefiting through education, through the support of policy. So they know that they can offer excellent breastfeeding care because they're backed by strong policies within healthcare facilities and communities. For families, because as you likely know, there are considerable monetary savings when people are breastfeeding over formula feeding. And then there's things like less garbage. So that's an example where communities actually benefit. And it radiates out through the involvement of fathers in breastfeeding, bringing babe to mom to breastfeed, holding babe, skin-to-skin contact for babies. There's so many ways that fathers are involved, as well as other children. So it benefits women and their infants, the people who care for them, it benefits families, and there are benefits to the community. So the great thing about the Baby Friendly is that our next slide shows everybody's doing it. It's just peer pressure. In the very best way. That we have all health authorities in British Columbia, including the Provincial Health Authority and BC Women's, BC Women's is currently certified. It's BC Women's and Quesnel Hospital are the only certified locations in British Columbia. But all of the rest of the health authorities are undergoing the process of becoming certified. So that's really exciting. That It's happening in all facilities, so all hospitals across BC, and also all community care settings. And then last but not least, next slide, is that the Kanesatake Health Centre in Quebec has become officially accredited, right? And it's the first First Nations health center in North America to be accredited under the Baby Friendly Initiative, or to be certified. Find me using these words interchangeably, accredited, certified. So that's really exciting. There's a lovely picture of all of moms and babes at the announcement of the certification of the Canada. Where do you think I got this? We took this photo from the Breastfeeding Committee of Canada website.
So right now, webinar people aren't seeing a PowerPoint, so if there's anything happening, it's just our BC people.
Okay,
Yeah,
so
maybe just
for all the webinar
today.
people, there's a great photo of a whole bunch of moms and
Yeah.
babes at Kanesatake the day that they made the certification announcement.
Okay.
There were a bunch of pictures of people speaking,
Mhm.
and I like this picture better because it's moms and babes.
Absolutely. And your favorite colour, Gerry?
Yes.
All in terms of purple and lavender.
Yeah, we see from our video conference insets that we have babies in Lake Babine in attendance.
Yes.
So, good on you, Lake Babine. It's great to see babies in attendance at webinars or video conferences. Carrying on, these days it's kind of like, so why certify? Why think about baby friendly? And one of the things is there's lots and lots of folks who are behind baby friendly certification. I'm going to reach across again. So it's part of Nutrition for Healthy Term Infants. So this was a federal government document that was developed by an advisory committee. And that advisory committee, when we talked about what can communities do to support breastfeeding, we said, there's one thing. They can implement the policies and practices of the Baby Friendly Initiative for hospitals and community health services. It's kind of like, what should we do? Oh, here's what we do, the Baby Friendly Initiative. Okay, next. And so the next thing is Perinatal Services of BC. They have backed the Baby Friendly Initiative. The next one, the World Health Organization has backed it. Next one, we have the Breastfeeding Committee for Canada. And I think the next one is the CPS. CPS, the Canadian Pediatric Society, Dietitians of Canada, and the Breastfeeding Committee for Canada have all endorsed the recommendations of Nutrition for Healthy Term Infants as issued. I had the great good fortune to serve on that committee with a wide variety.
Committee.
Yeah, to chair it.
Yes.
That just means
Lots of
I think there was a general consensus that I was the bossiest. Let's make him chair. But I had the great good fortune to work with a wide variety of people and talking about how we can most optimally feed infants. And so last but not least, our next slide is really about what Baby Friendly has meant to me. That again, I have the great good fortune to serve on the Baby Friendly Implementation Committee for Vancouver Coastal Health. And so that has brought a lot of fantastic things to Vancouver Coastal. It's been really exciting. First off, there's sort of the intersectoral collaboration. So VCH is a great big place with lots and lots and lots of services. And so it's so exciting to see people from hospitals, people from community health centers, people from childcare settings, all collaborating to work for certification under the Baby Friendly Initiative. We've also had a serendipitous outcome, and that's that as a result of everyone collaborating for the Baby Friendly Initiative, we've actually set up human milk depots in a number of places throughout Vancouver Coastal Health, including the office where I work in Squamish. And so moms who have a lot of milk can bring frozen expressed milk 2 health units throughout Vancouver Coastal Health where we keep it in a freezer and then I think weekly send it down to the human milk bank at BC Children and Women's.
And then it's tested, etc.
That's right. That it's processed to make sure that it's safe for distribution. It's predominantly used for the neonatal intensive care units, but also can be accessed by people if they have lots of milk. One day, some friends of mine, they're having a bit of issue with breastfeeding. They went to see the lactation consultant at BC Women's, and then they thought, well, let's just drop by that milk bank, and they were able to pick up some milk to feed their infants. So,
well, I know it's huge. It's huge at women's with all the preemies, big time. We've been there for the last 2.5 months, and depends so much on the donors.
Exactly.
Yeah,
It's a very precious gift.
it is.
and so it's so exciting to be able to work with all the providers all across VCH to collect milk and to ship it to BC Women's. So that's pretty much what I have to say.
Okay.
I'm gonna
I
turn
think we
things
should ask
over.
for any questions.
Oh, absolutely.
Is there anybody from video conference or webinar that has any comments or questions? We would love to hear. Just if you have anything to say, just make sure that's green. And yeah, go ahead. We'd love to hear from you. Anybody on webinar have any questions? Okay. When did Squamish get the milk depot?
Oh, someone needs to mute their speaker.
Yeah, is anybody,
Squamish, the milk depot will launch. It's not the paperwork isn't
Oh my
finalized. So we have the freezer,
Yeah.
but we don't have the agreements in place and signed. Because, lawyers have to get their pound of flesh. So once those are signed, we'll be able to move forward with milk collection. But everything is in place, so it's just a matter of whenever the agreements are finalized, then we'll be able to move forward with milk collection.
Okay. Does everybody know what Baby Friendly is? The Baby Friendly Initiative?
It's a knowledge test question.
Yeah.
We hope you'll know by the end of this session for sure.
Well, I guess Marianne will go on to the next section then.
Right, I'll just check in with Davina. Do the webinar people have their slides yet?
Yeah.
They do. Excellent.
And there is one question. Mount Curry would like to know, when did Squamish get the milk depot?
Yeah,
Oh,
let's
we
talk
answered
about
They
it.
did?
Yeah.
Okay.
Thank you.
Sorry,
We're
I'm
on
busy.
it. We're on
And
it.
hello to all my pals in Mount Curry.
Yes, hello.
Well, we are assuming that everybody is here today because you value breastfeeding, as Gerry mentioned earlier. And I just wanted to touch on why breastfeeding is such an important thing. And this quote from the 1000 Days Project notices that from the time when a woman is first pregnant until her child's first birthday is about 1,000 days. And that is a window of opportunity for particularly that child and mother, and all people on this planet are children at one time. So this is a very important window of influence for our community that can shape long-term health, stability, and prosperity. So this is why we are behind breastfeeding, not because it's a West Coast cool thing to do, but because it actually really can change lives and change our communities. We also know, as Gerry mentioned, that there are some strong feelings around breastfeeding, and not everybody is 100% behind it. We know that it is fraught with personal opinions both from families and women and also healthcare providers. So it's not like high care, cardiac health where everybody follows the rules and knows what's best practice. With best practice for breastfeeding, a lot of personal opinion gets mixed in there, and it can make breast practice very difficult. And it's particularly difficult when we look at communities where there has been a lot of experience of trauma. And I was very pleased when Shauna mentioned earlier, if this triggers anything for anyone, because so much of parenting and mothering and looking after our children triggers back. And for me, I start to tear up here. I went to residential school too, and this really resonates very closely with me. I have a brother lost to residential school. So this is a real strong commitment, and I'm sorry I'm tearing up here. But we know that we have a lot of trauma, and we know for women who were exposed and families exposed that we have a sense of this doesn't feel quite right. And how can we bring about healing in this regard and go back to our traditions where our nation survived on the land because of breastfeeding? So for me, this is a really very strong reason that I continue to do this work, because it saved my own life as a mother. So we know from Dr. Catherine McIsaac that she looked into how can we use breastfeeding to support health. And she says it's all very well to promote breastfeeding, but she strongly recommends that we shift that responsibility off the woman into the wider community and into the healthcare system. This is not a one-person job. This is something that needs to be done in the context of a supported system where the delivery of the programs is by Indigenous people for Indigenous people. So the Baby Friendly Initiative is a really great initiative that helps to reframe that responsibility for breastfeeding success. And it's not the mom that's going to fail at breastfeeding. The Baby Friendly Initiative realizes that women can be successful when we create the right circumstances to help them reach their own goals. And their goals may not include breastfeeding, but we can still support them to be the best mother that they can be using this initiative. So the lovely poster you're seeing there is a Picasso poster gifted by the estate to the World Health Organization to mark the designation of facilities who are accredited as baby friendly. So this is the only UNICEF and World Health Organization initiative that is across the world in developed and developing countries. It's such an important part of maternal child health. So the global criteria, or 10 steps, set out the standards, and you can find those if you go to the Breastfeeding Committee for Canada website, that you'll see listed up there under the BFI title. We know that this is a great framework that gives facilities the opportunity to evaluate their own practice and see where they're at. It guides them in thinking the direction they want to move towards best practice. And when they feel ready, they can invite a peer review through external assessment and go forward for designation. So I've taken those 10 steps and put them into themes to give you a quick whistle-stop tour and some success stories around the Baby Friendly Initiative. And at the end, I'm going to tell you some of the positive outcomes of that and then hand back to Gerry. So you'll see that the first of the themes is around policy and education. And as Gerry said, having a policy really guides our practice and gives us standards of care. It's kind of knowledge translation because it distills down the research and says these we have evidence are things that are useful to do. So we like to educate all our care providers and volunteers, and we like to let mothers know there is a policy and what to expect in care so they can advocate for themselves and say, I expect this kind of care because I know that's the best practice. And they can hold facilities accountable for care too. Here we have a picture at BC Women's Hospital about skin to skin. And they've chosen to put pictures up around some of their policy items to normalize it and have mothers know what it looks like and what they can expect. And that is actually one of the physicians at the hospital who delivered her own baby there and wanted to share this as an important practice. Here we have the, welcome Jonathan.
Joined by John.
Here we have, on the right, you will see the policy from Kanasataka that they have up in their health centre, talking about their promise of care. And as Gerry said, they are our first First Nations health centre that has been designated baby-friendly. Here you'll see Vancouver Coastal Health information, getting their staff on board. And I also am showing you a picture from Quebec, who in 1997 noticed that they had the lowest breastfeeding rates in Canada and decided this needed to be a health priority. And after the launch of Baby Friendly in 1998, they formed a committee. In 2001, they were the first province in Canada to have a provincial level policy. They also invested $900,000 a year in Baby Friendly at the provincial and regional levels to support this best practice. And it's not surprising that they have by far the most baby-friendly facilities out of the whole of Canada. I'll show you at the end how many we have. So the second part of the policy piece is that staff need the education to be able to do those practices with confidence. And here you see a picture of a lovely nurse lactation consultant in Iqaluit in Nunavut, and she came to a 3-day training with her baby, who is sitting in her Martique ready to go out on break. So I thought Lake Babine would particularly like to see that baby. I know that babies are always welcome at education. So the important part of educating staff is how we reflect breastfeeding back to our clients and patients is very important in their perception of the value of breastfeeding. If we kind of say, oh, it doesn't matter if you breastfeed, it doesn't convey the importance of breastfeeding. So knowing that and conveying that, we influence the mom's intention, her confidence, we can help her experience be a positive one. And as Gerry said, we're working on duration, so we help to reduce the risk of early weaning. Here is a lovely picture from the BC Aboriginal doula training. That was a pilot program from a tripartite pilot program. And one of the partners of the woman who was attending the training drew this very beautiful picture that really resonates so much with me, because so many women in remote communities are not able to birth close to home. And when we think of traditional practices with so much wisdom from traditional midwives, this is something that we really are wanting to work towards. But here is a very far-thinking project from Perinatal Services BC, looking at how do we build capacity and influence women in the community in a way that really speaks to the communities. So with policy and education, we're having everybody talking. It's not facilities deciding what to do. We need on their committees representatives from the community to say how this is going to work for them and what are the important things there. So it's a transparent process that's sustainable, that invites collaboration and conversations. We know that it is evidence-based care, as Gerry said. It's completely mainstreamed into all our important health documents in Canada, and it provides a continuous quality improvement method for facilities. And one thing we hear a lot is how much staff like to be able to practice at the best practice level.
We do have a couple comments.
Yes.
One person's asking, I think we actually can Google this one, but where can I get a copy of the policy for baby-friendly First Nations Health Center in Quebec?
They will share it.
Okay.
And
Is it online?
It is online, and If you would like to be in touch with me, I can introduce you to the staff there. They are very generous with their time, and they have travelled all over Canada, most recently to the Northwest Territories, to share their experiences. So thank you for that question. They would love to share with you. We will be sure that you get that.
And somebody else was asking about the carving and said they thought it was created by the husband. Do you know if that's true?
It's a drawing, not a carving.
It says, I know, I feel like I saw the carving.
I saw it a drawing.
Yeah.
He did it with pencil crayon.
Okay.
And it
that's how
so
started.
much looks. Maybe that was his carving design.
Yeah.
But it was incredible to see it take shape. And it was such a beautiful one that PSBC asked if it could be the symbol for the doula support program.
Thank you.
So our first theme was policy and education. Then, as Gerry mentioned, we are really focused on the continuum of care. And you may wonder why we want to talk about population health and health promotion. And that goes right back to the fact that we know that the circumstances of people's lives are so important in health outcomes for them. And you'll see that healthcare is 25% influence, but our lives are 50% of what's going on in the big picture for us. So it's kind of like the iceberg. What we see on the top is not at all what's going on underneath. And Baby Friendly acknowledges that you can't just tell people to go and breastfeed when they are having a lot of challenges in their lives. So steps 3 and 10 look to how can we move initiatives forward in our communities that put those supports in place for a better quality of life. And we know that the inequities and inequalities in healthcare reflect exactly into the incidence of breastfeeding, and especially the duration. When it's difficult for families, that's when they give up. So Dr. Rachel Ennie from Manitoba looked at the social determinants of health, particularly in First Nations communities. And she reminds us that it's not just the mother, it's fathers, community, it's supports in the community, but also to remember that women come to motherhood with their whole backstory coming along with them. So we need to have trauma-informed practice to support our communities. So I chose this picture of the Fountain of Neptune in Italy because the message we want to give prenatally is that most women have an abundance of milk. Many women are worried they won't have enough. So some cultures have fountains of milk squirting out of breasts in public. But what we have lost in Canada is our tradition of seeing women nursing long and well. In many First Nations traditions, children were nursed until they were 4 or 5 years old, and that is not at all common to see anymore. So where we once would see women like this who is successfully nursing toddler twins, we don't have that sense that we all have that abundance. That message has been lost to us.
But we have to admit, in society in general, you're going to be shunned. You're going to get rude comments. Even
part of this is
cover-ups, like
right.
Somebody else eating would have to cover up. Like, it doesn't make sense.
Absolutely. So the outreach to make it more normal and put it back out there is an important one to make that safe space for women to be breastfeeding. So in BC we have the wonderful pregnancy passport called Our Sacred Journey that talks about breastfeeding all the way through, and we'll see the whole body, mind and spirit focus of supporting the whole mother through there. And Lucy Barney from PSBC has what she calls the braid theory, where we look at weaving body, mind and spirit together to make a strong woman. And that is what we hope to do with our prenatal outreach. And here is a picture of a little book of breastfeeding stories from Nunavut, and they have collected stories from elders and mothers all over the territory, sharing their stories and what worked for them to build the strength and bring that back as a normal part of life in that community. Lots of lovely videos. I've put a couple of links on there for you to go and look at. The Creator's Gift to Mothers has lovely little cartoon drawings, and I particularly want to mention the importance of the elder and the grandmother that you see there, and the value of what grandmothers can do in communities and the changes they can bring about in health support. And a lovely study that I put there out of Alberta about 7 grandmothers in a rural community that really took on some important health issues and made such a difference in their community. So just little nuggets to share with you. And then Kanasataka, they shared a lot about their journey. It took them 10 years on their baby-friendly journey. So they had a lot of time for reflection and customizing and making this their own. And again, just like Dr. Amy, their practical experience, they're telling us it's not just the mother, it's the extended family, and it's the holistic approach. Particularly, they say that education needs to be tailored to the needs of the community. A lot of Western traditional education does not fit well with the oral tradition of most First Nations. And saying that particularly this next slide, I will read aloud because it humbles me every time I read it. They say, throughout the project, a number of lessons were learned. Beliefs about teaching and learning were challenged, and formal education was humbled. For example, unlike most Aboriginal communities before colonisation, mainstream Canadians placed great emphasis on the superior over the subordinate, the expert over the inexperienced, and the leader over the led. This type of approach was not successful in imparting information to this group of women. Prenatal classes were poorly attended, literature seldom read, professional speakers were respectfully tolerated. Instead, great value was placed on the wisdom of peers and extended family. Sharing and identifying with the experiences of others appeared the most popular route for passing information and prompting behaviour change. In spite of university degrees and professional associations, our message was impotent next to the loving advice of the ever-present mothers, grandmothers, aunts and sisters. So the Baby Friendly Initiative really acknowledges that we need a seamless transition between healthcare and peer supports in the community. And this is the first time that World Health Organization officially honoured traditional knowledge and the amazing value of traditional supports. And Sakeen in Manitoba noticed that their breastfeeding rates were way below the provincial rates, and they started an initiative where they educated staff in the hospital. They went into schools and educated adolescents, particularly boys, about the importance of breastfeeding and desexualized breasts. As breasts can multitask, they can be sexual and nutritional. We're not banning them from the fun department at all. They had a wonderful peer counsellor program for supporting women both before and after their babies were born, and a prenatal circle. So moms knew before their babies came what to expect in care. They were cared for in hospitals, they had peer counsellors, and the community at large was growing by educating youth. And when we look at that community effect, you can see Sakeen's breastfeeding rates are on the bottom line. You can see how far below the rest they were in Manitoba, and look how they climbed as a result of that initiative. So this gives us an opportunity to piggyback breastfeeding on all the other health agendas that are out there. There's a lot of concern around obesity, diabetes, sudden infant death syndrome, breast cancer. All of these are impacted by breastfeeding. So whatever table we come to, we can bring the value of breastfeeding to that table with a message that speaks to the agenda of those that have come to the table. And that's how we get the buy-in. We also know that we specifically need to reach out to vulnerable groups that don't necessarily come into our healthcare ambit. So when we are looking at and interviewing facilities going forward for designation, we ask about their entire population they serve, and is everybody equally represented in their services. Then we know we need to keep mums and babies together for breastfeeding to work well. We know that if we don't mess with breastfeeding by putting babies in nurseries, we know that breastfeeding gets off to a much better start. Gerry mentioned skin to skin. We know that that's an important, safe transition for babies from the womb to the world. We know that it regulates their temperature, blood sugar, heart rate, breathing. It's not just a nice thing to do, it's a very important health behaviour to stabilise babies. So we want to have mums and babies together in an unhurried fashion and offer help so that baby has some breast milk before they have their recovery sleep after the birth. In the early days of skin to skin, we'd want to grab the baby as they arrived over the perineum and jam them on the breast. And mums and babies said, whoa, this is not the kind of first date we were planning. We just need to eyeball each other before we get on to this breastfeeding bit. So we're much less hurried now and more respectful of mums and babies. And we promote this for vaginal deliveries, and on the slide you will see a mum with a section delivery who has her baby skin to skin. And look at the loving gaze between her and the baby's father. And where the mum was too ill to be with her baby, you'll see the dad is skin to skin with the baby. So hard for families who are delivering out of their community where their partners may not always be with them. But one example of trying to help with that is for women coming from the Bella Coola area, we have linked them with a doula training program here, so that each mom coming will be met at the airport by a doula and have her doula with her at the birth. So until we can bring birthing back to all communities, we have to look at what can we do to make it better.
We have another question on breastfeeding. Can mothers start to breastfeed if the baby is adopted by somebody else?
Yeah. Yes, absolutely, mothers can. And this is particularly something that I have just recently done a lot of work with Nunavut. There's a lot of traditional adoption there, and babies adopted out to family members, and looking at supporting adopted moms to breastfeed, or sometimes the birth mom wants to carry on at least providing milk or at least providing colostrum. Women can easily induce milk, especially if they have breastfed before. A lot of my background in Africa was working with HIV conditions, and there are a lot of HIV orphans, as is well known. And many aunties and grandmas would relactate to feed those babies.
Wow.
And that is done completely without medication because it's not available to most communities in Africa. So there are some good protocols. Anyone can be in touch. I'll be happy to share that.
So that's even with grandmothers?
Even with with Kukums if they wanted to. Yeah,
very interesting.
Absolutely. Always across time, women have supported each other with breastfeeding, which is why donor milk is such an important extension. And sometimes things are hard or go wrong, and it's more than one mom can manage on her own. So we need to put those kinds of supports in there. But we like to keep mums and babies together in the hospital, and you'll see we like to keep partners together with them in the hospital too. And here you'll see at BC Women's, you may have your partner on the floor, or if you're lucky and you get single room maternity care, the middle top picture, you see that there is a sleeping bench for partners. I visited a hospital in New Zealand where they provide queen-size beds, and the whole family, sometimes you come in the morning and grandma is in the bed too. We are absolutely, we just need to be always vigilant of safe sleep environments.
So that's a conversation about co-sleeping.
Right.
Because of course, in my day, it was normal, you just nurse fall asleep, so you could actually get some sleep during the night. And I've noticed now they're promoting not sleeping with your baby.
Right. So their Baby Friendly takes a different stance to that with a harm reduction approach.
Yeah.
We know from research that if you simply forbid parents to do things, they just do it anyway and don't tell you. So it's much better to provide information to reduce risks. Now we know there's a very high risk of SIDS in First Nations communities, and there are some things that really make it much more risky. Like if the parents are smokers, it's not a good idea to put their baby in bed. If the baby is sick or premature and the parents are smokers, it just makes the risk more and more. We know for women who have insecure housing and maybe sleeping on couches at friends, that's not a safe environment for babies to sleep either. So we're looking at that big picture and what can we do for each mom and baby individually to help them assess their risks. And one pilot project in the Carlton Valley is providing all babies born with a wooden box baby bed, which is easily transportable, and that's a way of keeping your baby close to you and in your room where you can scoop them up and breastfeed them if your circumstances for shared sleep on the same sleep surface are not safe for the baby. So we welcome those conversations of how can we reduce those risks. That if we keep our babies together with their moms, we see they breastfeed a lot more often, and when they breastfeed more often, as Gerry said, there's a lot more milk and less chance of weaning. So in addition to the safe transition of the newborn, we have babies more securely attached to moms. When they started rooming in a pilot project in Bogota, Colombia, they have 60-bed wards there in maternity, and they would push 2 beds together and put an experienced mom with a first-time mom and put the babies in the middle. And what they found was their rate of abandonment of babies went down by more than 80% because women attached to their babies and found that they had food security, they could breastfeed them, they didn't have to buy formula for them. And this was a way of being able to care for their babies. Moms and babies get more sleep when they are together. Babies are colonized with mom and family's microbiome, which protects them. And that way, when we keep partners together, the whole family is getting educated and on board for supporting breastfeeding. So we have assisted with breastfeeding right at the birth, and then this theme of supporting mothers always makes me think of riding a bicycle. In prenatal, many women are reading about breastfeeding, but it's the same as reading the manual for your bicycle and then suddenly your bicycle arrives and you have to get on and ride it. And it wobbles and you fall off and it doesn't feel like riding off into the sunset. So this is the time when we really need to support women to get their confidence and their skills up to know that they can manage breastfeeding. And if things are going a little difficulty with latching, they can hand express a little milk and feed their baby, who will think, thank goodness there is food after the placenta. Calm down, and then everyone can start latching in a much kinder and calmer way. So we want to support women to build their sense of self-efficacy, because we can't go home with every mom and live with her while she's breastfeeding her baby. She needs to do that herself. And when latching is going well, we don't find these kinds of terribly painful nipples, which would be enough to discourage anybody from continuing with breastfeeding. We equally support women who choose not to breastfeed. We like to offer them a lot of opportunity to discuss their concerns. For some, they may be adamant that they don't want to breastfeed. So what we then need to do is look at that little acronym AFASS from World Health Organization. Is it acceptable, feasible, affordable, safe, and sustainable? What is your water quality like where you live? What does it cost to buy formula up in the north? Is there a way that you can be supported if you can't breastfeed to have access to formula? For example, at BC Women's for the HIV program, the hospital buys formula for those babies for the first year of life. So there is a sustainable, safe way for feeding babies whose mothers are unable to breastfeed them. Once the mom has made her informed decision, we want to document that in her chart so that every other provider isn't saying to her, why aren't you breastfeeding? You should really be breastfeeding, because that re-traumatizes her every time. So once she's made that decision, we want to honor it. We might say, I see you have made your decision. Do you have any additional questions that have come up? We can always offer a door open to talk about it, but we don't want to be bullying her. We also want to teach preparation, feeding and storage of formula one-to-one, because we know that a lot of risks come from formula. This acronym is from the continuing education for emergency docs, looking at the misfits. And I see the T and the H have been transposed up at the top there. They got discombobulated. I'll sort that out before you get your handouts. But you can see amongst the most common reasons babies come into the emergency, things that are serious life risk issues like sepsis, heart conditions, seizures, intestinal catastrophes. Formula mishaps is up there with those. And the incorrect preparation of formula, too strong or too weak, can cause life-threatening complications for babies. And many moms mixing formula in the middle of the night might get things back to front. So we want to teach them all individually so we can take away that risk for babies.
There is another question. Oh, it just went. Just a second here. And we have a question for Gerry. Gerry, sorry. There's an oral health 101 soon somewhere, because I got conned out of the one done in Terrace, and the CHRs from the Nishka Nation really needs this training. So do anything about that?
So there are discussions about rolling that training out. That was pilot training.
Okay.
And so I don't have an answer right now,
Okay.
but I would expect within, say, 3 months, we should have decisions on how the oral health and nutrition training will be rolled out.
Okay, that's great.
Excellent.
Okay.
And oral health fits very well with breastfeeding. So
It's
very good question
Yeah.
right there, for sure. We'll come back to that one later.
And we haven't talked at all about helping each other nurse. I know we're talking about formula now, but we haven't mentioned, because that does happen, and you know that we help one another out with breastfeeding if we're having a challenge for whatever reason.
Right, we're coming to that.
Oh, good.
When we talk about exclusive breastfeeding.
Yes.
Very good forward thinking. Thank you, Shauna. We're just going to stay going in the order of the steps so that we, there's so many questions that come up. I could talk about this for the rest of my life, so I have to just stick on my slides and not get sidetracked. So we want to encourage cue-based feeding by watching the baby and feeding when they are ready, and not putting babies on schedules. And this applies equally to breastfeeding and formula feeding moms. We want to help formula feeding moms understand cue-based feeding and not overfeed their babies, because we know that this is one of the implications of childhood obesity. So helping moms with cue-based feeding and then encouraging breastfeeding beyond the introduction of complementary foods. So that will fit with Gerry's nutrition workshop, and we can't go into it here. It's just way too big a topic. But with the practical assistance, we see that moms are confident and competent, and we have more breastfeeding, and we therefore have significant cost savings in the healthcare system. So here's, we're heading into the zone of Shauna's question. We want to support moms to exclusively breastfeed because the benefits of breastfeeding are dose dependent. So if we can keep up exclusive breastfeeding, we see stronger outcomes. So you will sometimes see studies published that say breastfeeding doesn't protect against allergies. And then when we look carefully at those operational definitions, we see that they've included babies who've had formula supplements in hospital. So they were not exclusively breastfed babies. So when we read the research, we have to look out carefully for those definitions, which we will come to in a little minute here as well. So when supplements are medically indicated, we want to be able to offer the baby express breast milk from the mom or donor milk if the baby's not able to breastfeed. And one kind of donor milk is informal milk sharing, where in many cultures women have nursed each other's babies, sisters, cousins, aunties, and it's one thing if you know the person well who is nursing your baby and their health history. For the milk bank, donors are screened for the illnesses that can be transmitted through breast milk. So we need to know the person, and we would not want to buy breast milk on Craigslist, not knowing who that person is and how it's being collected and stored. That would not be a safe health practice. So if it's somebody that you know, then that's a time-old tradition. And Perinatal Services BC is busy working on a guideline for healthcare providers around the safety of milk sharing because it is such a time-old tradition. So Gerry mentioned Brazil earlier. They have a huge milk banking promotion, and they collected more than 100,000 litres of milk in a year for 300,000 premature babies. So we're not anywhere near there yet in Canada. All our milk banks except the one at BC Women's were closed down with the HIV scare. We didn't close sperm banks, we didn't close blood banks, but they closed the milk banks. Not very good sense. But we are coming back. We have one in Alberta in Calgary, we have one in Toronto, and we have one in Montreal in Quebec again, so we're building up. And we seriously want to have more depots, and that's another provincial initiative to expand the access to donor milk and also the collection points for milk donors.
Yeah, I spoke to collection in Vancouver Coastal Health, but collection is also occurring in Fraser Health. And as Marianne mentioned, there's plans provincially to roll that out throughout all of the health authorities.
Right. When BC Women's had the only milk bank in Canada, there were donors in Ontario who arranged with one particular airline would fly their milk in frozen to contribute to the milk bank. So women can be very determined in saying, we're not going to take that line down, we want to support other women. So part of the exclusive breastfeeding is feeding babies exclusively at the breast using no artificial teats. And you might think that's harsh and moms can't go out and leave their babies, but we know those artificial teats are really very implicated in especially gastrointestinal infections. So we see in many parts of the world where it's difficult to clean them, where they are definitely a health hazard and they reduce the duration of breastfeeding. So we really want to avoid them, especially in the early days while breastfeeding is being well established.
Do you talk at all about the development also of the jaw, of the mouth, the benefits of breastfeeding?
Exactly. So we know that suckling at the breast uses the oral architecture, they call it, the muscles and bone structures, in a way that babies' mouths develop well. Plus we don't have the dental decay that we see from bottle mouth babies. So we know that very often when bottle feeding was at its height in the culture, dentists were having to break the palatal arch of children and space it when their adult teeth came in because the arch of the palate hadn't developed adequately because the children weren't breastfed. So as you're cuddling your baby and nursing, you're not even aware of half of the important benefits going on there. Now with cup feeding, we know that babies are in the driving seat and it's very cue-based. They will refuse the same as they will at the breast, where with a bottle, the adult decides how much and how fast that baby's going to drink. But you'll see how pleasurable cup feeding is for babies and how much quicker and easier it is to clean a cup. Plus it's harder for mum and baby to get hooked on cup feeding than it is to get hooked on bottle feeding. So with the exclusive breastfeeding, we always talk about the data collection. We need to see that our efforts are actually paying off. Are we seeing a change in breastfeeding? So we encourage facilities to collect their data and see how they are doing. It's their own quality improvement. And we also see that in some provinces in Canada, we collect data provincially. We are very lucky to do that in BC. Across the country, there is no national unified surveillance system for collecting breastfeeding data. So with the definitions from the Breastfeeding Committee for Canada, we can at least compare what's going on in different provinces and territories now, where before we didn't have that consistency. So we are encouraging Public Health Agency and Health Canada to help us have a more national collection. Because, for example, our community health surveys are a very small sample, a very small snapshot in time, a lot of recall bias, not really good data for us. So this is an important health outcome measure that we are looking for. So I think we have mentioned all of these opportunities and benefits in our discussion. So thinking about the ethical practice and the WHO code for the marketing of breast milk substitutes, that is part and parcel of Baby Friendly, because we want to protect families from commercial pressure regarding feeding decisions. And we want to protect healthcare providers from a conflict of interest. If a care provider has been funded, they're research funded, or if they're going to education at banquets and dinners, and pediatricians even get to go on cruises for so-called education, we know that brings in a bias. We know that advertising direct to public creates a sense of equivalence, and mothers are not getting the scientific information or the one-to-one care that they need if they are choosing to formula feed. So we want to have a different kind of, in Canada we don't market all sorts of drugs through the media. We rely on healthcare providers to have an informed decision discussion, and we want to do the same with infant feeding. And we're very proud in BC that we now have a provincial contract that purchases infant feeding supplies and takes away that pressure of getting formula donated to your facility, which of course buys brand loyalty. They found that when a facility uses only one particular kind of formula, that mothers think, oh, this is the kind that the doctors and nurses think is best, and that's what they buy when they leave the facility. So inadvertently, we are part of the marketing team when we know that is not the best health behaviour that we want to support.
One of the positive outcomes of implementing the provincial contract was that prior to having a provincial contract, no one was really tracking how much formula got used. Now, because there's a contract, people are documenting when formula gets used. You don't just go and grab a bottle and feed it. They have to document.
Right. I do have a question about formula, because I know from our recent stint in NICU, they say whenever they have to get some weight on the baby, even if you're using breast milk, they want to supplement all the time with formula. And it's a real battle there, because
for
it really
some
is
premature babies, we add fortifiers to breast milk because the baby has been born so very immature. So sometimes they are using, they call them human milk fortifiers. They add that to breast milk, and
Is that different or is that the same?
it is. They are made by formula manufacturers, but they are. It's like adding. It's like adding extra nutrients to the breast milk because the baby is so fragile. It's not replacing breast milk.
Okay.
So we do advocate for not fattening the baby up with bottle feeding and formula just so they can go home. We advocate rather to have the mother in the NICU with the baby where she can hold it skin to skin and do kangaroo mother care and support that baby. Babies grow better when they're with their mothers, and we'd rather grow them with their mom than grow them on formula. So very good question. Thank you, Shauna. And especially our very fragile babies, there is a lot of concern to promote the best practices of keeping moms and babies together and giving them as much breast milk as possible and donor milk when mom may not have enough milk yet.
I definitely noticed as Indigenous people were overrepresented in that area.
Right.
Yeah.
We know from those determinants of health where we saw 50% of what makes you sick is your life is that if moms are not getting good prenatal care or from difficult circumstances, or there may be more illnesses like diabetes and things like that precipitate premature birth. So if we can, using our framework, back up to step 3 with prenatal and catch some of those things and educate in schools, so we can not maybe change the circumstances for the mom who is in the NICU right now, but we can change the course of the river by putting some different guidances in place. And that's how we want to use this initiative. It's not a quick fix, but it's about sustainable health that the community directs the course of, for sure. So looking at some of the outcomes from implementing Baby Friendly, we are sometimes aware that women feel very pressured to breastfeed because they know it is the best thing for their baby. So we want to emphasize that the BFI is not the FBI. We are not in the business of enforcing breastfeeding or bullying people into breastfeeding. Moms sometimes feel very under pressure, and there are some studies that show that women initiate when they're in the hospital. They can't wait to get out so they can stop breastfeeding and bottle feed. And that is not a good situation for informed decisions and dialogue and supporting that mother at all. So that's not where the BFI wants to go. The BFI is much more looking at the holistic kind of care that our First Nations Health Authority envisions in honouring the whole human being with the support of the community. So looking at who has been designated baby friendly in Canada, if you look at the column with Quebec, you can see that they have 105 of the 133 facilities, and their breastfeeding rates went up from 56% initiation in 1994 to 83% initiation today. So they really have turned things around by having a provincial policy level initiative with funding. And that speaks to how do we direct our funding in healthcare in a way that's going to give us really very good outcomes there. So you'll see also in Quebec our first Native Health Centre that's been designated. And as Gerry mentioned, we have 2 hospitals in BC, BC Women's and GR Baker in Quesnel, both up for re-designation right now. Ontario has their Ministry of Health on board, and they are just increasing there. And in BC, we now have a provincial-wide BFI coordinator appointed. And as Gerry said, all our health authorities are working on baby friendly, so I think we are seeing the tsunami building up. So get your surfboards out. It's coming your way soon. So we know that baby friendly, through research all around the world, has an impact on not only initiation, but exclusivity and duration rates. And that's exactly the variables that we want to influence. We know also that by increasing breastfeeding rates, we are decreasing the disease burden. Now, this study from Bartik and Reinhold was commissioned by the US government, who is actively supporting breastfeeding right now too. And they looked at illnesses that we know are lessened by breastfeeding. Necrotizing enterocolitis, otitis media, gastroenteritis, lower respiratory tract infections that require hospitalization, allergic dermatitis, type 1 diabetes. We have good evidence for type 2, but not strong enough to put it up there yet. Sudden infant death syndrome, childhood leukemias, obesity, asthma, and this doesn't even include the mom, where we know we have evidence for breast cancer, ovarian cancer, diabetes. So what they looked at, knowing those illnesses are impacted by breastfeeding, what are the cost savings for the country? And they figured if they could get 90% of women to breastfeed exclusively for 6 months, they would save $13 billion in healthcare in a year. So there is a dollar cost, but the even more tragic cost is they would save probably close to 1,000 child deaths, mostly infants, by increasing breastfeeding. And that is a personal cost to mothers and communities that is way beyond the billions of dollars to healthcare. So we see that if we can influence breastfeeding rates, we can make a real difference in the health of our community. And when we look at Dr. McIsaac's work, and I'll put her reference up for you next, she looked at a study looking at Inuit, First Nations, and Métis, and she looked at the incidence of otitis media, gastroenteritis, the lower respiratory tract infections and SIDS, and thought for unreserved First Nations families, exclusive breastfeeding for 6 months, and I wrote this down because I didn't trust my memory, for otitis media 10.6% less, for gastroinfections 41% less,
Wow.
for the respiratory infections 26% less, and for SIDS 24% less. Now that is a huge payoff for illnesses that are much more prevalent for our First Nations babies than they are for the rest of Canada. So this would be somewhere that it would be well worth our while. Here is Dr. McIsaac's reference that you can have a look at how they looked at that. And she is the Strategic Training Fellow for CIHR in the Action for Health Equity Interventions research program. Very good author to keep your eye on.
Another question, just asking about feeding with a cup. They're wondering how little can they be to actually feed them with a cup if it's some of your milk. Could it be a newborn?
It can be a premature baby.
And even a premature
Yeah,
baby.
it can be.
If everything's working right, there's nothing
Yeah,
there.
if they're not just on
Yeah.
tube feeding. And we know from the research, they measured babies' oxygen saturation and their heart rate. And with bottle feeding, babies often hold their breath. They have apneas
Yes.
longer than 20 seconds, which they don't with cup feeding. And we know also that they don't have the braddies where their heart rate drops when they cup feeding that they do on bottle feeding. So bottle feeding is actually quite stressful for babies, especially when adults are setting the pace. Because we kind of go glug, 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 and it's a really quick, we think it's quick and easy.
Yes.
But for the baby, physiologically, it's quite stressful. So when we're doing individual teaching around artificial feeding, we are helping mothers understand how to pace bottle feed and watch their babies breathing and see that they are comfortably feeding when bottle feeding is necessary. So cup feeding is just a little knack that needs a bit of practice, and you'll remember from the slide that the baby had a little towel under his chin, because when you're first learning you have quite a few dribbles.
Yes.
And moms get a little anxious because their milk is going all into the baby's clothes instead of in their tummy. But with a little bit of practice, you get good at pacing that, and it's a very simple way and very handy. You never have your breast pump not work when you have the power out. You can hand express into the little pump and feed your baby. It's empowering for women. You can be camping on the land where you have no electricity and know that you can be safe and clean your equipment really well.
Thank you.
Absolutely. So we're almost done here, where we'll open up for questions. We know then from all of these things we have spoken about that the mom is central. She is the primary care provider for her child. She's the primary decision maker. And it is our job to support her in her own community to make the choices that are right for her and her family, and offer her the information that she can make an informed decision. And this is a lovely little poster from Australia saying everyone looks up to moms who breastfeed. And that's how we want to influence our culture and have a respect and a value for a tradition that really and truly is a lifesaver. So I'm going to hand over back to Gerry with the next slide to wrap up for us.
And I just wanted to present this excellent study that was done in Australia, because we've talked a lot today. And what they learned when they did their study was that the process of implementing the baby-friendly initiative was what changed in initiation rates and duration rates. So just going through the process, whether or not you're certified under the baby-friendly initiative, that undertaking the process and talking about this and implementing policy and making these changes, that's what changes your breastfeeding rates. And so it's a very exciting study because it says it's the doing. The talking is great, and we need to do that, but the doing is what changes breastfeeding rates and duration. So it's a very exciting study. And yeah, if people want to write to me, I can certainly provide it.
Okay, it's 25 after 11 now.
Absolutely.
So we're just going to wrap up here. So send any last minute questions or comments, and yeah, do you want to finish up?
Well, I can just say, again, my pals up in Mount Currie, I was talking with Rachel, the health director there. She and I want to create a set of posters that show women breastfeeding in meetings, at the coffee shop, at the gym, and breastfeeding kids
at the board table.
At the board table, that's right.
You're awesome. You're awesome.
We're loving it.
I don't know if you can see saw a newborn baby there. A little tiny one on the table. Keep on going, sorry.
Just that. We really want to show people in the discourse of their daily lives breastfeeding children of all ages.
Yes, in all places.
Mm-hmm.
Yeah. That's great. Oh my gosh, there's a big comment, but I don't think I could even get through that.
Oh my goodness.
I'll try to maybe skim read part of the question because it's a big one. I'd like to extend the invitation to join the BC Friendly Network Community Practice Purpose. Provide a forum for a collaboration, inspiration, learning, resources sharing. What else am I saying? Yes, so she's just actually extending an encouragement to join. Oh, we have a question. Is that on video conference? Yeah?
Are we going to be getting the PowerPoint on the website?
Yes, we're going to have the PowerPoint up on the webpage, the baby-friendly webpage for UBC Learning Circle. We're going to put it up there and also put up the video from today.
Awesome, thank you.
And anybody who registered, Davina will also send out the information too.
And I think the invitation to join the BC Baby Friendly Network is a really great suggestion.
Yeah.
It's a network across the province where across all the health authorities, including the First Nations Health Authority, about monthly meetings of sharing resources and encouragement and support for the journey. It's important that we share our resources together and everybody's not making brand new resources all the time.
Yeah.
So if you would like to be part of that community, if you just Google us or look at the PSBC webpage, I think you'll find a link for us there, and we would welcome you to join that community for sure.
Okay, so I'm afraid the video conference is going to shut off in 2 minutes, so I just want to make sure that I thank everybody for joining us today, everybody on video conference and webinar, and I want to especially thank our guests for coming and sharing today. And Davina has worked hard behind the scenes with all the technology and all the other details. Thank you. Some of our upcoming sessions are April 20th. It's making syrups for coughs and cold. And that's going to be with Ellie and Jessica. They've been here before. So they're going to be preparing preserving traditional medicines, and this is their syrup edition. April 26th, we have a traditional plant practitioner, and that's Carolyn Victor, who will be joining us. May 5th is going to be an exciting one for Indigenous male youth. And we're going to have Preston Gano as part of the panel, and we're doing that with the Langley School District's Aboriginal program, and we're going to be actually doing that from Langley. And doing that with Kwantlen Nation. May 10th is Falls and Prevention. May 18th is Bug Sprays and Lotions with Naturopathy. And May 24th, we're going to have Ernie Cardell back again. And he's going to be talking about more detailed co-occurring disorders. And our last one for the year until the fall is May 26th, and we're having Mark Point back again. And he's going to be talking again about Aboriginal student success, but going into the side of how grandparents are involved in impacting in a positive way Aboriginal student success. So I hope you will join us. Thank you for being here today. And goodbye, everybody.
Thank you for having us.
Yeah. Bye-bye.
Bye for now.
Do you have something?
Yeah.
There we go.
Can you eat broccoli while you're breastfeeding?
Yes.
Yes.
Yes,
Oh,
you.
we're off.
Oh, we're off. Yes, you can.
We'll just keep going. Just keep going till we disappear.
The question was whether or not you can eat broccoli while you're breastfeeding.
Yeah.
Absolutely. There are no foods not to eat while you're breastfeeding.
Just alcohol.
That's right. That typically Mother Risk has some excellent guidance.
Yeah.
So motherrisk.ca, is it? Motherrisk.ca, they have guidance
Oh,
on
okay. That's a good one.
that if you just have a drink, then there's no reason to stop breastfeeding. If you have more than one drink, maybe you should, as they say, pump and dump.
Yeah. And some medicines, some medications.
That's very limited though.
Very few.
Very few medications. I have a list,
You have a list.
but I don't
Is that
know them.
also Mother Risk?
Mother risk would be good too.
Mother Risk?
Yeah.
Okay, we put the link out. So Mother Risk, Google that one, and that'll guide you for breastfeeding.
Yeah,
And
there's
for most medicines, there's a safe alternative. So if you are prescribed something that's not great with breastfeeding, they can usually find an older, tried and tested drug that they have more information on that will work as well.
Okay, thank you.
Would you feed formula to a breastfed baby while our babysitter within the first 6 months?
So it sounded like the question was, can you feed formula to a breastfed baby while they're with a babysitter during the first 6 months? Is that right?
Yes.
Yes.
Yes, you certainly could. If you were trying for exclusive breastfeeding, it would be helpful if the mom could leave a little bit of express breast milk for the baby. But if that's not an option, it's a great idea that the baby is breastfeeding when mom is around. So any amount of breastfeeding is good. It doesn't have to only be exclusive breastfeeding. And depending on the mom's circumstances, how she can make things work, if she's needing to offer formula now and then, it's definitely an option.
Okay, I think we're going off the air. Awesome to see you guys. I'm so glad you brought all the babies.
Yes, and your brunch looks delicious.
It has looked very tasty.
Oh God! That looks very good indeed.